Hello, good evening, everybody. How are you? I can see a couple of you have joined online. My name is Dr. Yasmeen Sajjad. As you can see, I'm one of the MRCOG examiner and tutor, and I think some of you have attended my lectures. So today, it's a very important topic that we're going to talk about for just an hour or so, and uh, the way I do that, I don't just give lectures, so I do it very interactive. So please be ready that if I call your name, that you unmute your mic, and then we can have an interactive dialogue. Because I usually like to put some scenarios and I make it very realistic for you, as if you are dealing with these cases in a clinic, in a hospital setting. That's exactly the format that you will be facing in your actual MRCOG-3 exam. So today, this is a very important topic, and most of the time, the candidates doesn't know much about it. It's not box standard consenting or ethical dilemmas, but it's actually how to put it to the practical in terms of to the practice in terms of when you're dealing with patients. So thank you very much for all of you joining this session. I think as some of you are constantly coming and adding on. I can't wait for much longer because I have got other commitments later on as well. So those who join, they hopefully they pick up, and I'm happy to answer any questions in between. So, as I said, this is an important topic, and today's lecture will focus on consent, professionalism, and ethical decision making in complex clinical scenarios, or areas that are not only central to safe clinical practice, but are also heavily tested in the MRCOG 3 exams. So you may be coming across some ethical dilemmas, you may be coming across some scenarios where these features will be tested, okay, and there will be special marks for these types of knowledge testing. Beside knowledge testing, checking your professionalism and your ethical decision making. So what makes these stations challenging is that the right answers is really about knowing the law or quoting guidance. Instead, candidates are assessed on how safely, humanely, and professionally they can manage uncertainty cases, distress, and conflict in real time when you're dealing with patients. So today, sessions is therefore being designed to move beyond theory. So I'm not talking about theory, I'm not talking about by knowledge, implication of knowledge, but we will look at how examiners think, what they are actually marking, and how small changes in the structure and language can make the difference between a borderline pass and an excellent score. So the learning objective of, let me move this slide. So the way I'm going to do it, as initially I said, that I will put a scenario, and then there will be a role play, then you can be the role play, and then we will have the examiner dialogue, like I usually do in my lecture. So today, the learning objectives would be, or by the end of this session, you should be able to demonstrate a structured approach to consent and ethical dilemmas that is examiner safe and clinically sound. Also assess and articulate capacity clearly, including recognizing when capacity may fluctuate in cases of these different clinical scenarios. And how do you balance patient autonomy with professional responsibility and patient safety? And use layman language and behaviors that scores marks for you in these types of scenarios, including your empathy, escalation, and documentation, and avoid the common traps that lead to otherwise kind but unsafe answers. And I must tell you that examiners, they love it when candidates sounds like they know, but the but the station is what the station is testing. Okay, so the key and crucial insights to frame this MRCOG Part 3 session, today's session, is that being empathetic is not enough. Okay, being knowledgeable is not enough. The exam actually rewards candidates who are structured, who are safe and human in that order. Okay, that is very, very important. Beside the knowledge, you need to structure your answer, you need to be safe, and you need to be human. And that's why we talk about putting empathy and sympathy in your communication. And I must tell you, many candidates fail not because they are uncaring, but because they assume that a patient's refusal automatically equals a valid decision. So if the patient is saying, no, I don't want this treatment, you don't accept it, okay? That if the patient said no, it doesn't mean no, because you need to think about why the patient said no, why this patient's, it's important to dig into it, and what is safe for the patient, or that respecting autonomy means agreeing to everything a patient asks for. And you will see in the next few scenarios. So across all ethics and consent stations that I have put, the same core principles are repeated. For example, empathy first, capacity assessment, how much the patient has understood, balanced information that you give to the patient, and an appropriate decision framework, that you create, and also escalation to your seniors. And after that, clear documentations, because these could have medical legal implications later on. So, um, so with that, we will transition into our first scenario. And keeping in mind, let's move on to this scenario, which I'm going to put on the screen. And this is one of the most commonly examined and most commonly failed scenarios that candidates score less or they fail. And these scenarios test your understanding of the capacity, particularly when capacity is fluctuating in the patients, and how you act when a patient initially consents but later refuses in sometimes life-threatening treatments. Okay, so what I'm going to do is I'm going to put a scenario there, and who wants to volunteer? I'm just going to give you a few seconds, see who wants to volunteer. And if not, then I will basically call the name. So better you volunteer yourself, otherwise I will call your name. Okay. Nobody wants to volunteer? So, Sania Khan, can you please unmute your mic? Sania Khan? No? You don't want to come? Okay. Mansoura Ismail? Hello. I tell you, I'm not going to keep talking, right? Somebody volunteers so that we can have an interactive dialogue here. Come on. Mansoura Ismail?
Yes, ma'am,
No?
I'm here.
Oh, well done. Very good. Okay. So, where are you calling from, or where you're connecting from?
Ma'am, I'm from Pakistan.
Pakistan.
Yes.
Which city?
I'm from Islamabad.
Islamabad.
Yes,
Very
ma'am.
good. Very good. And how's the weather there?
Ma'am, it's good.
It's
Like,
good?
yes, ma'am. It's a transition
Ah,
between the winters and this arrival of the summer.
absolutely. That's
Yes.
beautiful, isn't it?
Yes, exactly.
Okay. Have you taken this exam before?
Yes, ma'am, once.
You have taken that. Okay. So, have you attended any of my lectures before?
Yes, ma'am. Your infertility lectures in previous med exam course.
Okay, so you know how I do that. So we will read this together. Okay, so
Okay.
you're gonna be the on-call registrar or doctor or at a level of ST3, ST4, and you
Yes,
are
ma'am.
on a maternity triage. So you read this, then we'll go through the dialogue, and then together I will go through the scenario with you. Okay, for the answer. So
Okay, ma'am.
you have got 32-year-old woman. She's 30 plus 5 weeks with the severe preeclampsia and is advised to commence IV magnesium sulfate as you do in these patients when they have severe preeclampsia to prevent the risk of going into full eclamptic fits.
Yes, exactly.
She initially consents, but later becomes confused and refuses treatment. Your task is to assess her capacity, manage consent and refusal,
Okay.
explain and justify your decision making. So I'm the patient, okay?
Okay.
I agree that you asked me, so Mrs. So and so, you are pregnant and your blood pressure is rising up, and to prevent you going into fits and because it can be dangerous for you and your baby, we're going to give you this medication which will help, bring down your blood pressure and prevent you getting your condition deteriorated. And I say to you, yes, doctor, that's fine. Whatever is best for me, can you give that to me? Whilst you are preparing, you come back and I say to you, doctor, what are you doing? I'm not going to take this medication. Okay.
Okay.
So, how are you going to convince me to take this medication? Initially, I agreed, but then I refused. So, how are you going to take this further with me?
Okay. Okay. What's your name?
Just call me Yasmin. Okay?
Yeah,
Yeah.
Yasmin. Okay, okay, Yasmin. I can understand that you are 30 week pregnant and you are having raised blood pressure along with the proteins in your urine, and you need emergency drug, which is magnesium sulfate, which will protect you from having fits. Initially, you were happy to get this medication, but currently you are refusing to take it. Is there any specific concern for refusing taking this medication?
Doctor, I do not want this drip anymore because I feel you're trying to poison me. I felt fine. I was feeling fine earlier on. Now everyone is panicking. I really don't understand. What is the problem?
I can understand.
I feel that you're going to poison me.
I can understand your concern, but this medicine is not a poison. I assured you that this drug has been used in a similar condition in a lot of patient, and it does cause some benefit to the patient rather than causing any harm. So, from where did you get a concept that it's a poison? It's not a poison. Okay.
Everybody's panicking. Everybody panicking.
And the people who are panicking around are just they're concerned with any deterioration in your health condition. So their panic is not related to this medicine. It's just to expedite giving you this medicine to prevent your condition from deteriorating and you landing in having some fits that will be like dangerous for you and for your baby as well. Okay.
So if the patient continues to refuse, what do you do next then?
Okay, I understand your concern, and I assure you that nothing will be done without your prior permission. Okay, and whatever you choose for yourself, whether it benefits you or it's not beneficial for you, we will respect your wishes. Okay.
Okay.
And I'm going to document this in your record, that you are if you're ready, you are pretty sure that you don't want this medicine. Then I'm going to document it in your record that it's refused by you. And so and if you have anyone with you to help you in making this decision.
No, no, no. So I do not want it. I do not want it. So
Okay.
what are you going to do next? I refuse. The patient continuously refused to take it.
Okay,
So
when
what
you
are you going to do?
okay, if you are refusing to take this medicine, your wishes will be respected, and no intervention will be done without your prior permission. Okay,
So
so
you won't give me. You won't give me.
no, I will not give you this medicine as you are not allowing us, and you are not happy with getting this medicine. But what I can do is that I will keep you in the under strict monitoring for the any and we will monitor you for your so for any signs of deteriorations, like if you have any feeling of any dots in front of your eyes, or you are feeling like uh, 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 you are we will monitor your reflexes as well, and your urine output as well. And if there is any deterioration in your condition, then we will try to manage it earlier. Otherwise, without taking this medication, you are at risk of having fits. We will monitor you for any signs of the pre-fit or the pre-fit condition, in which the patient do feel like they have
Okay.
dizziness and they
So
have
if
some
the
blurring of
patient,
the vision.
yeah, okay, the patient condition is deteriorating. So what you going to do?
So, if the patient condition is deteriorating, we will make all necessary arrangement for the delivery of the baby. And patient will be, I will inform my consultant, and I will take multidisciplinary approach. The blood bank team and hematologist and ICU team and anesthesiologist should be taken on board, and also the pediatrician as well. Patient will be after all necessary arrangements, the
Okay,
bloods and the
yes.
urine investigation.
Okay.
Patient will, yes.
Okay, 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 okay. Thank you. That's what I wanted to hear. Okay. So, yes, the patient said that she's frightened and she feels that, you are poisoning her. So, yes, you, as a candidate, you say, yes, I can see this feels frightening because her capacity has been muddled. During
Okay,
the time she initially agreed, that later on she refused. So her capacity has been affected, of course, because of her condition deteriorating. And then the candidate, the doctor should calmly say, yes, I can see this feels frightening and I want to slow things down so we can talk calmly. But the patient continues to refuse. So, what do you do next? This is what I asked you. So, of course, before accepting or acting on their decision, I need to assess whether she has the capacity right now. Okay?
okay, okay,
Because, of course, with all her, the condition deteriorating, her capacity has been affected. So,
okay,
when I was keeping on asking you, you have to verbalize to
okay,
assess the patient capacity.
okay,
Yes,
okay,
that's very, very important. You are constantly talking to the patient, but you're not assessing her capacity. Can
okay,
she understand this information? No matter how much you talk to her, she may not understand the information. She cannot absorb the information. So your job is to assess her capacity. Can she
okay,
retain it long enough to decide? Can she weigh the risk and benefits? Can she communicate a decision, right?
okay,
So capacity is the decision specific and time specific, and it can fluctuate in severe preeclampsia. And I wanted sort of this from you, and you said it in the end that yes, you will inform your senior, consultant or whoever, but rather than if the patient is still refusing and you said no, I'm not gonna give you if you don't want to take it, that's not the answer. You
okay,
would wait for her to go into full eclamptic fit. In this situation, yes, you recognize there's a temporary loss of capacity, but as a doctor, you have to proceed under the best interest of the patient, and you
Okay.
escalate to the senior obstetrician, and then you document clearly in the,
Notes.
sorry, you document clearly in the patient's in the notes. Okay.
Okay.
Now, so
Ma'am, what
if you
will I document?
sorry,
What
that
will I document?
yeah, you clearly document that, you gave the patient information. Initially, she agreed, but as her condition was deteriorating, she refused. So that means her capacity of understanding was muddled or
Okay.
clouded. Okay,
Okay. Okay.
so this clearly said in a court of law that will cover you. You informed your senior. You also documented that the patient initially verbally agreed, because in this situation, you don't sign documents, you don't
Okay.
sign consent form. It's verbal consent, isn't it? So then if you document that, I think that will be good enough for
Okay.
you.
Okay.
Okay. So you have to say explicitly, explicit capacity assessment is mandatory mark domain here. Okay. You recognize fluctuation, it shows advanced ethical reasoning. So, if you say to me that, yes, I'm going to assess her capacity in this condition, usually that their capacity deteriorates. That means you have got the know-how of advanced ethical reasoning on these type of scenarios. Okay, and you act in the best interest to prevent
Madam,
serious
what are the
harm.
key words we will use to assess her capacity? How would we come to know
Yeah.
that her capacity is deteriorated?
So in this situation, you will, and I will show you the answers in a sense. What is the
Okay.
best, that you assess her capacity by checking her understanding, whether
Okay.
she understands. Like when you were saying to me, is the best, and I said, I don't want it. You are poisoning me.
Okay.
Now, that shows her capacity is muddled, because
Yes, yes.
why would the patient in a hospital thinks that
Full.
you are poisoning her? That means her understanding is being affected. She cannot retain the information that you have given her. Okay, and
Okay.
also the ability to communicate with the patients. Why 10 minutes later or 15 minutes later the patient was communicating absolutely fine with you, and she agreed for you to give her the injections to improve her condition, but then later on it changed. So that has been affected by her condition. Okay, so in this
Okay.
situation you act in the best interest of the patient to prevent serious harm, and you also escalate to the seniors, and that is the safe practice that you do. Okay,
Okay.
so in this case, if you see, I have put three answers. So the fail response, like, if you had said, that you said, I would explain the benefits of magnesium and try to reassure her that it's safe. If she still refuses it, I would respect her wishes. That's what you did initially, right?
Okay.
I would respect, I would not give you. No, in this case, you cannot wait, because she
Okay.
may end up in full-blown
Eclampsia.
eclampsia.
Okay.
Okay, but why this fails? Because you did not assess her capacity. You assumed that by refusing the patient, that's a valid decision. You took that, her decision as she does not want it. So that is unsafe. So it sounds kind, but clinically it's negligent, right?
Okay.
So if this answer you give, that means you get a fail. The
Okay.
pass response would be, I would assess her capacity by checking understanding, retention, weighing of information, and ability to communicate. If she lacks capacity due to acute illness, I would act in best interest and escalate to a senior, right?
Okay.
And why this is passed, I put it here because capacity assessment is stated. You talked about capacity, you talked about the best interest framework, and also escalation to your senior colleagues. That is
Okay.
safe, but a little generic. Now, how would be an excellent response? And that is, if you say to me, I would first acknowledge her distress and slow the interaction. I would then explicitly assess capacity, recognizing that capacity is decision specific and time specific and may fluctuate in severe preeclampsia. If she currently lacks capacity, I would proceed under a best interest framework to prevent serious harm, involve the consultant obstetrician, document the assessment carefully, and continue to explain each step to her, right? And why it's an excellent score? Because you showed empathy before ethics, right? You were
Okay.
nice to her, you gently explained to her, uses examiner's trigger phrases, okay? This is what we want to know, that as you know, your empathy is there, okay? You're not a robot, you're not working like a robot, but you have got empathetic behavior towards your patient, and you link that capacity to her illness. There's a fluctuating capacity, okay? And also you demonstrate leadership and documentation. That means leadership, you're escalating to your senior, and then you document it, because later on, it can protect you from medical legal problems as well. Okay?
Okay. Okay, ma'am.
Yes?
Thank you. Okay, ma'am. Thank you.
Very good. Very good. Okay. Who wants to come next? Come on, it's not that hard. Who wants to volunteer? Michael? I'm picking up just name. Michael? Come on, guys. Please don't waste time. Unmute someone. Volunteer, please. Hello? Anybody there? Michael does not want to come. Okay. Dr. Ikra. Dr. Ikra? It was not that hard. Okay. Do you want to come for this scenario? Hello? See, I can just read this, but it's honestly, this interaction won't be good if nobody wants to volunteer. Okay, so nobody wants to volunteer, so I'll just read it for you, okay? So this is a prima gravida at 38 weeks. She's requesting an elective cesarean section due to fear of vaginal birth. There's no obstetric indication, okay? So, you ask as you do in the clinic, the first thing you ask, why does she want to have a cesarean section? And then the patient tells you that she had heard horror stories and she does not want tearing or of her pelvic area, or because of the risk of incontinence in here. Okay. So the way you do with that will, so the candidate say, thank you for sharing that. The fear around childbirth is very common. So that is that you give your empathy, and it's important that we explore it properly. So you want to understand what is the reason or rationale behind her refusal to go for a vaginal birth. So the examiner will ask you, do you agree to the cesarean section? And you will give the patient cesarean section. So the candidate answer would be, I need to explain the risk and benefits of all options and be clear about what is clinically appropriate. And you will explain that you balance the risk of cesarean section versus vaginal birth, and also discuss the implications of future pregnancies. And in this, important is that consent requires both patient agreement and a clinically appropriate option. So you cannot just willy-nilly give her vaginal birth, but a cesarean section, agree to cesarean sections, but you need to have a discussion of appropriate options. So in this case, the management plan would be to respect her autonomy, you maintain professional boundaries, and you offer alternatives, birth planning and counseling. And also, you can send her for a second opinion or to your senior, escalate to your senior. And that is what we would expect you to do in your clinic, because if you see the patient for the first time, you cannot agree for her to straight away go for cesarean section. You always escalate it to your senior. You document the discussion that you had with the patient and discussion pros and cons for both vaginal birth versus cesarean sections. Okay, so the autonomy means it's if the patient says that it's not equal to entitlement of surgery. That is what I want to get across, that if the patient refuses, that doesn't mean automatically you agree to give her surgeries. So there should be non-directive counseling that scores higher than persuasion, and you maintain the professional integrity, and that is what we test in your MRCOG exam and as a level of ST3, ST4 in the clinics. So in this situation, if you said, if that's what the patient wants, I would consent her for a cesarean section. So if I was the examiner and I asked you that, would you agree for this patient to have the cesarean section? And you say, yes, that would be a total fail for you. And why this will be a fail? Because you misunderstood the autonomy, which I said initially, that autonomy is not equal to entitlement for surgery, and there's no professional boundary there. So, you offer non-indicated surgery for these patients. So what would be the past response? That is, I would explain the risk of cesarean section and vaginal birth and suggest a vaginal delivery as it's a safe overall option for these patients. And this would be pass because you communicated the risk of cesarean section to the patients, and compared it with you gave full pros and cons about that, but slightly directive and limited exploration of the fear. So in this situation, yes, if you had the patient says that I want to have a cesarean section, your first question would be, it's your first delivery. Why do you want to have a cesarean sections? And of course, she would spill her fears. Why? Because her friend had a vaginal birth and she had third-degree tear or second-degree tear and all that. So as a doctor, that's your responsibility to help her with those fears and heard different stories about the vaginal birth. So in this situation, the excellent candidate response would be something like this, that I would acknowledge her fears and explore what worries her most. I would provide balanced, non-directive information about both modes of delivery and explain that while patient preference is important, I also have a responsibility not to offer procedures without clinical indication. I would then offer alternatives such as birth planning, perinatal mental health support, and consultant review. And why this scores highly? Because you are respecting the autonomy and integrity. It's a non-directive counseling, and there's a shared decision making between you and the patient. Okay? So the next scenario, anybody wants to volunteer? No? God. You guys just want to listen. Nobody wants to interact. How you got to interact with the examiner? It's better to practice your techniques now rather than in the exam. Okay.
Ma'am, I will do.
Who is
Mansura.
that?
Mansura.
Mansoura, very good. Excellent. Excellent. Okay. So let's start. I like this. Right. So you have got a woman at 36 weeks. She presents with reduced fetal movements And when you did an ultrasound, it confirms no fetal heart. Okay. So
Okay.
I'm the patient.
Okay.
You did my ultrasound, and I was looking at the screen and I could see there was no heartbeat. I said,
Okay.
Doctor, is is everything okay?
Hello, Yasmeen. Uh,
Yeah.
I can understand that you are pregnant by 36 weeks and you were having some reduction in the fetal movements for a few days. And now you are here to discuss your ultrasound report. Is this so?
Yes, yes. You just scanned me and I didn't see the baby heartbeat. Previously, I had seen the heartbeat. Is everything okay?
Yes, I am going to discuss it with you in a short while. But before discussing this, this ultrasound report has some concerning news. Do you want anyone to accompany you in consultation?
What concerning news? What concerning news, doctor?
There is like some problem with the baby's heartbeat that I will discuss with you in a short while. But please let me confirm that is here someone to accompany you?
No, I'm on my own.
Okay, okay. Actually, your scan report is showing that there is some problem in in baby's heartbeat. Like the baby is not
What is the
baby's heart.
problem? What is the problem?
The baby heart is not beating, and
What does that mean?
it means that your baby is no more inside the womb. So this
But my
I
baby is inside the womb.
no, your baby is inside the
I
womb,
could
but
see
it's
my
heart.
baby there.
Yes, you can see your baby there, but the heart of the baby is not beating.
So the baby is dead.
Yes, I'm really sorry for being the bearer of this news. I can understand that how much stress it brings to you. You were having so many plans for these coming babies, but unfortunately, this is so that your baby is the
Thank
heart
you.
is not beating
Thank
anymore.
you. Thank you. Thank you. Thank you. Thank you. What did you do? Why did it take you so long to tell me my baby is dead? Okay?
Because it was for breaking the bad news, we have to ensure that
Yes.
the
No. No. It's yes, you set the scene, but I'm telling you, yes, you say, I'm really sorry. I have some very difficult news you give, and then say, I'm afraid your baby has died. You don't go around beating around the bush. You were just beating around the bush. Your
okay,
baby is no more in your womb. There's a problem with the heart. There's a problem with this. No, you
okay,
give the bad news bang, and then you wait. Let them absorb.
reactions, right?
Yeah, okay.
Okay,
So it's really, really in this situation. Yes, you're right. Is there anybody? But I told you, I'm seeing actually the scan and I'm telling you the baby heartbeat. I saw the previous scans and the baby heartbeat was not was absolutely fine. Now, at that minute, you say, I'm really sorry, your baby has died, right? And then silence,
okay,
because rather than going around and round beating about the bush, is no, just get the bull from the horn and give that bad news, right?
okay,
That is what we want. Okay,
okay.
you use clear language, avoid euphemisms, allow silence, right? Acknowledge
Euphemism
emotion.
is something like giving a positive hope, false hope.
Yeah,
Euphemism.
false hope. Yeah, yeah,
Okay,
yeah. You were giving her false hope.
okay. How
Okay,
come?
your baby, there's a problem with the heartbeat. Problem means a bradycardia or
Yes,
misbeats
exactly.
and all that. But
Okay,
actually, the baby is dead.
okay,
Yeah.
okay,
So it's really, really important that even if nothing you do, this will catch you full marks. And I tell you, about I don't know, 30 to 30 years back or something, when I was doing my MRCOG exam, I remember I had a station there, a similar
Okay.
stillbirth. Patient came and patient was crying, right? She came with reduced baby movements, right?
Okay.
And this question was saying this heartbeat is not there. Honestly, I just came, I checked the patient name and date of birth, and I said, the scan report shows your baby is dead, and kept silent. And the role player, because in those days we had the role players, she was crying like anything. She was
Okay.
not even stopping crying, just let that. And I passed that station because I let her take her emotions out. So, doctor, you're second. First, you are a human. Okay?
Ma'am, but some
So,
people says that you shouldn't annoy the uh, role
how
player.
how you annoyed this patient? How would you? You are
They're like you
annoying the
should give some
patient?
directive, like some hints before disclosing the actual
No,
news.
no. If the baby's, how can you give a hint? The baby is dead. How can you give hints?
Okay. If there's like some
If the
problem, then we
baby
can give
is
it.
No, see, hints is different when the patient has come. You need to understand why the patient has come, and need to get the results and all that. And yes, you're right. You got someone to you can give you the bad news or all that. But in this case, the scenario is saying the baby is dead. You have to tell her the baby is dead.
Okay.
What do you do in the clinic? Tell me. In the clinic, you scan the patient, isn't it?
Yes,
And you're
exactly.
sitting, you're scanning the patient, you put it on your probe on the heart, and the heart is still. What do?
Ma'am, we
Am I
don't
going to
touch to the
give you
patient,
some?
but we call someone else with her.
Yeah,
Like we
someone
ask her
come.
some
Yeah,
bring
that's
someone else.
fine.
Yes,
Call
yes, exactly.
someone else. But
Yes.
you don't say there's a problem in the heart, isn't it?
Yes, exactly. We
As
have to
an
disclose.
ST4, yeah, as an ST3, ST4, I would expect that, you can tell at, 32 or 36 weeks, you can see the heart there. But
Okay.
what I'm trying to do is that do not go and beat about the bush. You say,
Ma'am, but
I'm
we
really
don't do
sorry.
it at that place straight away. We just like we make a meeting, like we call her husband or any relative of her. Then we talk to her. But while doing scan, we don't disclose her that what's happened to you.
Okay,
She's saying that
but
you are the one who is doing the scan. So I should I confirm her name and NH number even then? If she's saying that
see,
you are the
like
one who is
you
doing the
are,
scan.
but when you start the scanning, you don't start the scanning without checking her identity, isn't it? Do you
Exactly.
scan the patient without checking her identity? You
No,
have
ma'am.
already checked that identity
Yes,
before.
exactly. Exactly.
You would not just go and scan anybody without checking their identity, isn't it?
Yes, exactly.
So you know that this is the patient that you're scanning, and
Okay.
the your scenario is telling that the woman at 36 weeks present with reduced fetal movements. Ultrasound confirms no fetal heartbeat. It confirmed. So it's telling you she has got IUD. So
Yes.
yes, you can say that, is there anyone come, outside? And the patient is constantly asking you, is there a problem? Then you say, I'm really sorry. I have some very difficult news. Have a bit of a pause and then say, I'm afraid your baby has died.
Okay.
But do not shy away from saying your baby is
Dead.
dead. It's
Okay.
exactly the same when you have a report where it shows that the patient has got cancer. You cannot just yes, the same thing comes there. I'm really sorry. I have some very difficult news for you. Give a bit of a pause, and the
Okay.
report shows that you have got cancer, right? Then
Okay.
let them absorb a silence, and then you can, give whatever you need to. Okay. So this is all about, how you give the bad news.
Ma'am,
So
in my exam, I have a patient, like I have a case with Paget disease with adenocarcinoma. And when I told the role player that you're having cancer, uh, she was like, she just stand up from her seat and she was making a lot of noise that what my doctor, cancer, 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 what is this? She, I was like, I was just shocked. How would I counsel her? I said, okay, let's just settle down, and I will tell you that this is like very rare. It turns into a, it spread very, very late, and it's diagnosed at early stage. I will refer you to a vulval clinic, and your biopsy will be taken there and stuff like that. Then, but she wasn't like getting calmed, and in this scenario, what should I do? She was like, she was just for about 1.5 minutes. She was like, cancer, cancer, cancer.
So
And
this
I
was an
think
actual
I'm failed.
exam or in the course?
Actual exam. I thought I'm
Okay.
failed because I have annoyed the role player
No.
by this
So in this
diagnosis.
situation, yes, you let them take it because it would be in her script. You would
Okay.
not have lost marks on that if the patient is behaving like that. They actually, the script tells them to do like that. And in this
Okay.
situation, yes, they want to see your empathy. I'm really
Mm-hmm.
sorry. Yes, I understand. This is a bad news for you, but we have, whatever treatment or this is, we're going to refer, and I'm going to get my senior involved. That is the thing you do. The same is that she's not going to run away and all that because they have a script to follow. And
Okay.
it's the same thing happens in the real scenario. The patient
Okay.
do get irritated, but then they calm down because that is a, any that's the how to say, it's a reaction to
Okay.
something that they were not expecting.
Okay.
Yeah.
Okay.
So in this situation, avoiding the word died, you will lose mark. Rather
Okay.
than saying there's a problem in the heart, your baby is no more in your womb, and all those,
Okay.
it's not right. You're giving her false hope.
Okay.
Silence demonstrate emotional intelligence, right? And early logistics is equal to common exam failure. So let's see what would be the fail response. Unfortunately, there's no heartbeat, so we will need to discuss induction and postmortem options, etc., etc. So jump to logistics, avoid emotional processing, and sounds cold and transactional. Past response will be, I will explain sensitively that the baby has died and offer support. You're offering clear language, basic empathy, but lacks depth and structure. And what would be an excellent response in this situation? I would give a warning shot, clearly state that the baby has died, then allow silence. I would acknowledge her emotions, avoid rushing into decisions, and ensure immediate emotional support is in place before discussing next steps at a later time. So use silence appropriately, prioritize emotional safety, and demonstrate advanced communication skills.
And what's emotional safety?
Hmm?
What does mean by emotional safety? Like let her
Emotions.
diffuse her
Yes,
emotions?
yes, yes.
Okay.
So you just let her take her, because if somebody is very angry and you are also talking, that is going to irate further. So you just give her that bit of a safety. Okay.
Okay. Okay.
Okay. Who wants to do next? Okay. So this is a patient with severe anemia. She refuses blood transfusion for religious reasons, because you do come across such cases in sorry, where I am. I think I'm in yeah, in Jehovah's Witness patients. So in this situation, I understand the risk, but I will not expect blood under any circumstances. That is the patient, when the patient states that. So in this case, as a candidate, if the candidate say, I respect your decision and I want to ensure you fully understand the risk and alternatives, you will confirm capacity, explore blood sparing alternatives, and you will also clearly document her refusals in the notes. In this case, you respecting autonomy sometimes means accepting outcomes and In this case, it's, you find it uncomfortable. So capacity plus informed refusal is equal to decision must be respected. Disagreement does not override, it's not equal to override it, and documentation is a safety requirements. So in this situation, if the patient is refusing blood transfusion, the failed response from the candidate side will be that I will explain that without blood she could die and strongly advise a transfusion. So why? Because you're, coercive tone, you disrespect her autonomy, and that's a big no-no for the examiner. So this is a red flag that this can for us that the candidate does not understand, how to convince the patient. So the past response in this situation would be I would confirm capacity and respect her refusal while documenting carefully. Uh, in this situation, why this would be a pass question, that you acknowledged her capacity, you respected her autonomy, and you also explored the other alternatives. And the excellent response in this situation would be that you confirm her capacity, you ensure she fully understands the risk, you explore sparing alternatives, you respect her decision even if she disagreed, and documented the discussion clearly with your senior involvement. And why this is an excellent response? Because of balance, autonomy, and safety, and also showing professionalism under discomfort, and excellent documentation awareness there. Okay,
So,
so
ma'am, in this case, we have to ask about the alternatives like self-salvage technique, right?
yes, yeah, yeah,
That
yeah,
that whenever there is a massive hemorrhage, then we have to
yeah.
ensure that the self-salvage facility is there.
Yes, yeah. So
Okay.
that's what you do in it, because you discuss all the other alternatives with the patients, okay? And also documentation, involvement of a senior. So always remember, in these situations, you always get your senior obstetricians, because you are at a level of ST3 and ST4, and these type of decisions you're not taking on your own. You always involve your senior, you always involve, like, other specialties or your MDTs, and your second opinion as well. So these type of questions which we went through, the teaching points, important is empathy first, as I said to you in earlier on, that you are a human first, okay, doctor second. So you should show the empathy, you check the capacity, you balance the risk explanation, and you have your professional boundaries as well, and documentation and explanation, okay? So the exam, it rewards you for being safe, structured, and human, not to be heroic and to take drastic decisions. So the way I put this is that the safe ethics script, in step by step, the way you do that, empathy is first, always starts here. Acknowledge the patient emotions. Yes, like I understand how upset you are, or I understand, this is bad news for you. So these are the things that you are acknowledging, the emotions, okay? And I'm really sorry to hear that. These are the different things that you show your empathy. Slow the interaction. Say, I can see this is distressing, and I want to talk this through calmly with you. So that will show the examiners that you have got the empathy there before ethics. Then step number 2 is to check the capacity. If the patient is refusing, why is she refusing? Is she confused? Or she's taking some high risk decision, which is not appropriate? okay, which you feel is not safe for the patient, why she's refusing. So you need to check her capacity. Ask yourself and say it loud. Can the patient understand this information, what I'm giving to her? Can they retain it long enough? Can they weigh the risk and benefits? Can they communicate a decisions? Okay, like we discussed in the case of the preeclampsia in the first case. So the golden point here is that capacity is decision specific and time specific, and it can fluctuate. Then comes the information and risk, a balance, not persuasive. That so explain the options, you explain the risk and benefits. It should be non-directive. You should not impose your decision on the patients. So avoid pushing them towards your decisions, okay? So you should not say, I would strongly advise, but this is what I would advise. This is what would be in your best interest, okay? So you can say, my role is to explain the options and support you to decide the best option for you, okay? So the framework over here is capacity is present, you respect the autonomy even if you disagree. Capacity is absent, if the capacity is absent, then you act in the best interest, like the first case we talk about, the preeclampsia. And no clinical indication, you maintain the professional boundary. And the examiner sentence, consent requires both patient agreement and a clinically appropriate options, okay? And also the safety net over here is that involve the senior colleague, escalate to your consultant, involve MDT if relevant, document clearly and contemporaneously, okay? I would escalate to a senior colleague and document this discussion clearly. And do not rush to the ending. Reassure ongoing support, right? Do not overload with logistics, saying we will support you through this and you don't need to decide everything right now, okay? So if your answer includes empathy, capacity, structure, and safety, you will pass any station. But if it's flowed smoothly and confidently, you will excel. So I just put ECIDSC. These are the short mnemonics, which shows empathy, capacity, information, decision framework, safety net close. Okay, and if you're lost in a station, go back to the next letter. So it means that, if you feel that you don't remember anything, just be yourself. Show that empathy. Talk about information, involving your senior. Talk about MDT. Okay. So I think this brings us to the close of this session, and I want to leave you all with one key message here, that MRCOG Part 3 ethics and consent stations are not about being heroic, persuasive, or what can I say, emotionally dramatic. They are about being safe, structured, and human consistently. Okay. And if you remember nothing else, remember this: examiners are not asking whether you agree with the patient, but whether you can recognize the risk, assess the capacity, respect autonomy appropriately, and act in a way that protects both the patient and yourself as a professional, okay? And across every scenarios that we have discussed, there's fluctuating capacity, non-indicated cesarean section, breaking bad news about the intrauterine death, or refusal of treatment, for example, not taking the blood transfusion. There's a same framework that applies here. So always, as I said to you, start with empathy. check the patient capacity when decisions are high risk or contested, okay, and provide a balanced information, pros and cons, okay, and use the correct decision-making framework for them. And whenever is needed, escalate it appropriately to your senior and then seal it with documentation. And when you do this, you are not just passing the exam, you are actually demonstrating the behaviors of a senior ST3 or ST4, and leading to future consultants. So if I'm your examiner and you showed this to me, I would say that yes, this doctor is a safe pair of hands. And also, I'll be marking your global score as high, because the global scoring as an examiner that's given to us is that whether you want this, can you feel this candidate, you can leave this candidate safely on the labor ward or in your clinics in your absence, or you would want this candidates to be under indirect supervision or under direct supervision. So that is level 1, 2, 3. So by showing all these capabilities, you are at a level 3, and that is a global pass for you. Okay, I think that's enough for today, although I did all the talking, but next time I would like all of you to participate. And thank you very much for Mansoura for being a good sport and volunteering to take part in this. Okay, guys, have a good evening. Anything else?
Thank
I
you,
think
ma'am.
we should.
Thank you.
Okay, have a great evening. Bye.
Allah Hafiz, ma'am.
Allah Hafiz.